very fortunate that Minister Butler came in to see our pain assessment tools in practice and to learn about the importance of pain assessment and pain management in palliative care and end-of-life care. We are live streaming this event today, and we'd just like to make everyone aware of that. There is photography, so please let the photographer know, Irene over at the side here, if you don't want your photos shared at all. I'm your MC, Camilla Rowland, and I'm CEO of Palliative Care Australia, and we are really delighted to hold a Parliamentary Friends of Palliative Care event in conjunction with Pain Australia. So important when health peaks can collaborate and work together for a good common cause. And as I said, we're really delighted to partner with them. You would have all seen Minister Butler was able to join us for a brief time. I understand today is the busiest sitting day of the 2 weeks. And we originally were hoping that Minister Butler would be able to speak, but he's had to Zoom off to other duties, and we're just appreciative he could come. I'd also like to acknowledge Louise Miller-Frost, Senator Helen Polly, Helen Haynes, Rebecca Sharkey, Dr. Monique Ryan, and Leon Rebello. Our co-conveners, Senator Karen Little and Senator Raf Ciccone, will be coming along a little bit later and joining us and having a few words. We also have apologies from Federal Minister Katie Gallagher, Senator Stirl, Dr. Anne Webster, Andrew Wallace. I'd also like to start off by really thanking the Pharmaceutical Society of Australia for sponsoring today's event. And I could see there was a whole team here of supporters. So thank you for coming along. It's just fantastic. I'd like to start off as well by acknowledging that we're meeting on the lands of the traditional owners here, the Ngunnawal people, and pay my respects to their elders past, present and emerging, and thank them for their ongoing contribution to this community. We have Mary Atkinson here, who's going to do our welcome to country this morning, and thank you, Mary.
Good afternoon, everyone. Apologies for my sister, Violet. She has double booked herself today. Apparently, there's a lot happening here in Parliament House today. So you've got me as a ring-in. So I'm her younger sister. And I am also a proud Ngunnawal elder. But it's my pleasure. I just said, I'm in the right place. I've got a funny leg. I love that app down there. I went and tried, and it just shows you face, and I thought how amazing is that, when people can't always relay how much pain they're in, there's a diagnosis there that can give you your relief, your medication and pain relief that you need. And palliative care affects most of us in our lives. So I've seen a lot of my families when they're on their last. I wish one day that they will find a cure for cancer, because cancer takes a lot of my people at an early age. It doesn't discriminate against anybody, that dreaded disease. So I'm hoping one day that we can get a cure for that. But palliative care is very important, that we are treated with dignity and we are not in any pain as we are going. So I really like palliative care. One day I will probably be in there, hopefully not too soon though. And I'm a mum, I'm a nan, I've got 14 grandchildren, I've got 2 great-grandchildren, I've got 2 sets of twin grandsons, and they are my joy, my world. They, what life is going to be for them. They be a little bit tricky because one set is very identical. So I can't tell them apart if they're not in the same room. So I said to one the other day, "Oh, which one are you?" And he goes, "That's for you to find out." I said, "You're the cheeky one." So, so it's about what we're going to leave for them, in our future, because they are our future, our young ones. And their dad is also Ethiopian, so we call them our little Aboriginal Ethiopians. And they're 8-year-old twins. So, but they're my world, as I said, my grandchildren. Thank you for the invite. I'm sorry that I'm a ring-in, but like I said, people are busy. So, and it's important that we have a welcome to country, you know. So I am a proud Ngunnawal elder, and I've been given permission by my elders to perform my welcome to country. There's a bit of a tradition around that where we, our elders say it's your turn. Now, when you can show respect for our country and you can be respectful of yourself. My dad's country, so I'm also Wiradjuri. So my dad's Wiradjuri, and they have a word, the Wiradjuri people have a word called Yinjamara. Yinjamara is to have respect for yourself, respect for others, respect for what's around us, to be polite, to be gentle, and to go kindly, to honour each other. And with all this stuff that's going on in the world today, I think it's a great philosophy to live by. So I always try to live with Yinjamara. Every time a formal welcome to country is given, it continues a tradition that has always been a part of Aboriginal culture. It was always given by the way of welcome when permission was granted to visit different tribal areas. There's been a little bit of controversy about welcome to countries lately, if people haven't heard. We're all Australians in this room, aren't we? Yeah? So it's not about welcoming you to Australia. It's all about welcoming you to the lands of the very first Australians. It's like me turning up to your home. You have to welcome me in there first before I can just push my way in the door. So, and I don't get nasty. I'll come in when you invite me in. So it's not about welcoming you to Australia, it's about the traditional people of that country. When we talk about traditional country, we mean something beyond the dictionary definition of that word. For Aboriginal Australians, we might mean our homeland or tribal or clan area, and we mean more than just a place on that map. For us, country is a word for all the values, places, resources, stories and cultural obligations associated with that area and its features. It describes the entirety of our ancestral domains. It is on this land that my ancestors and Ngunnawal people cared, lived, learned and raised their families, and we continue to do that today. I pay my respects to my elders, both past, present and of the future. I also acknowledge and pay my respect to any other Aboriginal or Torres Strait Islander peoples that may be here today. Now, we are only 3% of the population in this country, Australia, so I'd like to acknowledge our non-Aboriginal brothers and sisters and ask that we walk together on this country for true reconciliation in this country so that we all can have equality and be equal in this country and equity. So I'd like to say today, I hope we learn a lot about what we need to relieve our pain. And I did say too, sorry, I forgot to acknowledge the dignitaries. I forget to do that. So everyone, dignitaries that are here, I'd like to acknowledge and thank you for being a part of this today as well. So Mandangur, which is thank you in my father's language. Welcome, welcome, welcome to Ngunnawal country. Thank you.
Thanks, Auntie Mary. That was great. And as we think about supporting Aboriginal and Torres Strait Islander communities, we know that at the moment the NACCHO have an Aboriginal and Torres Strait Islander palliative care plan project, and we look forward to supporting them as that develops over the next year as well. So thank you. So pain affects us, as Auntie Mary was saying, pain affects us physically, emotionally and spiritually. When it's not managed well, it can leave people suffering unnecessarily in their final days. Pain Australia and Palliative Care Australia are both committed to improving how pain is assessed and managed for people at end of life. And that is really our theme for today. Before we talked in a panel session coming up in a few minutes, we really want to welcome Monica Boogs, who's the CEO of Pain Australia, to really talk about the pain assessment tool that they're committed to. And it gives you a really great example of the way that contemporary pain assessment and management is moving in Australia. Welcome, Monica.
Good afternoon, everyone, and thank you, Camilla. I think, Mary, you and I are about the same height, so this is perfect for me. I'd like to begin by acknowledging the Ngunnawal people and other traditional people and pay my respects to elders and presents. As you came in today, you may have seen the My Pain Assessment Communication Tool, or IMPACT as it's known, that's on display in the room. And if you haven't, please have a look at this and all the other pain tools at the back of the room later on after this event. IMPACT was created because for so many people living with chronic pain, one of the hardest parts is actually finding the words to describe it, particularly to a health professional, to be able to get the healthcare they need. And I know I have had that same frustration when you're trying to describe the pain that you're in and you just can't. And that's because chronic pain is constant and life-changing. It can stop you doing the simplest daily tasks, and yet for most it is totally invisible. It's something you feel every single moment, but struggle to explain, and also so many people struggle to be believed. For years, we've tried to measure that pain with numbers and faces on a chart. But pain isn't just about where it hurts, it's about impact, it's about how it changes your life. It's complex. And for every single patient, it's different. And being able to communicate this to your health professional is the foundation of good healthcare. That's why Pain Australia is proud to showcase the new tool, which has been developed in partnership with Dragon Claw Charity. This has been designed over 15 months by patients in Australia, Canada, and the US, all drawing on their lived experience, and they've shaped the tool at every stage. It helps people living with pain tell their story, and it helps them tell their story clearly and confidently. Now, it might look simple, but it's not a typical pain chart. It's easy to use and helps patients prepare for appointments, track their experiences, and show health professionals the full picture. And it also provides the words for patients for when they're in the room with their doctor. Because when communication improves, healthcare improves. Patients receive that better support and can manage their pain better. And the work on this tool is continuing. Our consumers are refining impact, they're using it, and they are providing their feedback, which I love. They tell us what they like and what they don't like. And that's what's so great about having people with lived experience use it. And we want to do this to make sure it stays practical and relevant. Because too often, people living with pain are unheard, and impact helps them find the words, tell their story to their health professional, and be truly understood, because pain does matter and we want to manage it better. Thank you.
So that is a really good example of a pain assessment tool that has been developed that is very user-friendly. And similarly, we now have AI involved with, Pain Check being one of the leaders in Australia and internationally in an electronic assessment tool. So there's a variety of tools, different tools for different people and different needs. But this tool that Pain Australia has got is something that's really now part of cutting edge evidence-based assessment. Along with our discussion about Pain Australia, we'd like to take the opportunity to launch the new Palliative Care Australia plan and strategic plan. I'd like to welcome Dr. Peter Allcroft, our chair, to the stage to launch the new strategic plan.
Thank you, Camilla, and thank you, Auntie Mary, for a warm welcome to country, beautiful Ngunnawal land. Thank you very much. You're not a ring-in at all. As the chair of Palliative Care Australia, it is my privilege and pleasure today to launch the new strategic plan to encompass the next 4 years to the end of 2029. Can I acknowledge the work of the Palliative Care Australia staff, our CEO, Camilla Rowland, the directors of the board, our members, consumers, carers and the stakeholders who had a collective input into the strategic plan development. Quite simply, the goal is to strengthen access to quality palliative and end-of-life care for all Australians, regardless of where they might live, and build on the previous work of the strategic plan. The 4 pillars supporting this goal are advocacy through collaboration, and that strengthens national policy. To strengthen the systems that we work in, the complex healthcare systems that we all work around. To raise awareness and support for palliative and end-of-life care, and ensure that education and knowledge is translated into practice. To enable a skilled and confident and competent workforce delivering palliative care. And I think 2 current key examples highlight the work that is required to ensure this quality palliative and end-of-life care. The new Aged Care Act commenced on the 1st of November, and Palliative Care Australia wholeheartedly supports this endeavour and embedding palliative care aspects into the Act. Palliative care really did a lot of work advocating for having palliative care in this Act, and that's part of the work that we do. An essential aspect of the Act is to ensure that all palliative care funded aged care have access to skilled quality care, and to that we need to provide education. We need to support our consumers, our carers, our healthcare professionals with education and implementing evidence-based knowledge for older Australians at the end of life, an essential pillar of our strategic plan. We'll also hear today about the concerns of the community around provision of adequate and quality pain management for all Australians. 2 recent studies from Australia, one from the Medical Journal of Australia published just yesterday, and one in Pain Practice earlier this year, highlight the critical need to provide consumers, carers, and healthcare professionals with quality education to support the delivery of quality pain management for our patients. I commend to you the Palliative Care Australia strategic plan for 2026 to 29 and encourage you to explore all the detail it contains, our goals and the collective actions required to ensure strong and safe quality palliative and end-of-life care for our community. I would like to thank the Minister for Health, Disability and Ageing of Australia, the Honourable Mark Butler, for the work that he leads and his support for Palliative Care Australia to enable that work to ensure that quality palliative care is available for all Australians. Can I also thank Senator Kerry-Ann Little and Ralph Ciccone for leading Parliamentary Friends of Palliative Care. Your support and your enthusiasm is essential to ensure that the corridors of Parliament House are buzzing and all members of Parliament are aware of the demand for quality palliative care. Thank you.
Thanks, Peter. And as you probably saw before, we always all go into a panic as soon as we hear those bells ring. But can I just say, I'm absolutely delighted that Senator Karen Little is here as our new co-convener. And before she steps on the stage, her advocacy for Indigenous health social services brings a new perspective to improving cultural care. And I have seen Karen at a few different events over the last few months, and she is very passionate about good quality health and about palliative care and end-of-life care. So I'd like to welcome our new co-convener and leader of the Parliamentary Friends Group of Palliative Care, Senator Karen Little.
Well, thank you. It really is terrific to be here and talking to the most important people in the room, and that's not me, that's you. I'd like to acknowledge Ngunnawal and Ngambri people. I'm an Aranda woman from Central Australia, although I'm a South Australian senator. Both my parents are Aranda, and we have considerable lived experience, not just in Alice Springs itself, but also in a remote context. I'd like to also acknowledge Peter and Camilla, the terrific work and the work you've done with us to get the Friends Group going, and yourselves as distinguished guests, ladies and gentlemen. I'd also like to acknowledge Pain Australia and the work that it's doing here today. It is truly an honour to co-chair the Parliamentary Friends of Palliative Care alongside Senator Ralph Ciccone, who quite frankly jumped at the chance to support you in the important work that you do. This group was established to provide non-partisan forums for parliamentarians to engage with Palliative Care Australia and key stakeholders. But importantly, our fundamental mission is to listen, learn, and celebrate palliative care with you and raise awareness of the challenges faced by Australians who need end-of-life support. Palliative care is not just for older Australians, it is for all ages and includes everyone connected to the person who is gravely ill. We seek to help put palliative care and end-of-life care at the centre of reforms in health and aged care. You would know that approximately 400 people die every day from life-limiting illnesses in Australia. Palliative Care Australia knows that the need for specialist paediatric services will grow, and an estimated 41,775 children and young people aged 0 to 21 have potentially or will potentially benefit from these services by 2027. Responding to demand as well as increasing accessibility, particularly for our most vulnerable people, must be front of mind, as is regional and remote Australia. People in major cities were 4 times more likely to receive Medicare subsidised palliative medicine attendance and case conference services than those outside of cities. Palliative Care Australia's new strategic plan for 26 to 2029 addresses these critical issues, and developed in 2025 in collaboration with state, territory members and health stakeholders. It builds on previous work and outlines actions for national reform. I'm just going to outline some of those. Embedding palliative care as a core function across all aged care settings through the new Aged Care Act, strengthening links between primary health and palliative care, and supporting First Nations organisations in designing and delivering culturally relevant and responsive palliative care models. Further developing its skilled specialist health practitioners, the incredible workforce that does this important work. Increase partnering with service providers, community groups, individuals, stakeholders and families. And also improving equitable access to essential medicines that help manage palliative and end-of-life care while supporting the growth of community-based models of care that are tried and tested. The plan's focus is diverse population groups, regional communities and our most vulnerable people, and to remove systemic barriers and tailoring services based on individual circumstances. And that's what really excited me about looking at that strategic plan. You know, I was really delighted. One of the nicest things I've done this year was to attend the Oceanic Palliative Care Conference in Brisbane and to see the latest innovation and to talk with many of the exhibitionists. Sorry, you know, it's, people here, you get used to having allergies and it puts you actually very anxious, more anxious than being in the chamber. This premier conference brought together over 1,000 experts, and in 2025, the theme, Connecting Systems for Better Care, highlighted the necessary collaboration that's required across sectors. And I congratulate all of those who were honoured on the evening at the National Awards event, the runners-up, the winners, and everyone who was there to cheer them on. From my home state of South Australia were 2 outstanding South Australia Award recipients. Dr. Priyanka Vandisman of Flinders University, who received the Emerging Leader Award, the Women's and Children's Hospital Paediatric Palliative Care Services team, which received the Outstanding Achievement by a Team Award, and in the town where I was born and grew up, in Alice Springs, and relevant to my portfolio as Shadow Minister for Indigenous Australians, Territory Palliative Care in Alice Springs, Central Australia, Northern Territory, who received the Outstanding Achievement in Aboriginal and Torres Strait Islander Care Award at those awards. While we celebrated their contribution to palliative care on the night, I look forward to working with you to acknowledge and better appreciate the work that you do day in, day out through the work of the Parliamentary Friends of Palliative Care Group 2. Thank you for making time to learn more about this important topic, and I welcome you to actively participate in our Friends Palliative Care Group at future events, and look forward to hearing from you if I can help you with anything. Thank you. Not me.
Thank you very much, Karen. And you'll be pleased to know that in this collaboration, we have over 15 different national stakeholder health peak bodies engaged here today, which is fantastic. So I don't think Senator Ciccone has made it yet. So we might wait until the end, and he might be available then to have a few words. It's, as I said, with the bills, you never know when people are being called away. And I believe he's also chairing the Senate today. So our next item and our main item for today is the panel discussion. And this is going to have a palliative care physician, a pharmacist and a consumer on that panel, facilitated by Simon Corbell. Simon is the chair of Pain Australia, an experienced leader in public policy and governance. He's also the chair of the State Electricity Commission of Victoria. I heard he was being mobbed by supporters in the foyer recently, and we said if only we could get that much excitement about end-of-life care, that would be awesome. He holds a range of board chair and non-executive director positions. Simon previously served as Deputy Chief Minister, Health Minister and Attorney General, amongst other ministerial portfolios during his term as a member of the ACT Legislative Assembly. I would like to welcome Simon and all the panel members up to the stage, and I'm going to introduce them all. We have Dr. Peter Allcroft, who's the chair of Palliative Care Australia. He's a senior staff specialist at Southern Adelaide Palliative Care Services and the clinical lead for the State Palliative Care Network. He has an interest in models of palliative care for patients with complex chronic medical conditions. He co-founded the Motor Neurone Disease Clinic, which is based at Flinders Medical Centre, and is the deputy chair of the Motor Neurone Disease Association of South Australia. We then have Felicity Bates in a beautiful PSA t-shirt. And Felicity is a senior clinical pharmacist with the Mid-North Coast Local Health District, bringing over a decade of experience in palliative care. She is currently participating in a national pilot program led by the Pharmaceutical Society of Australia, which integrates pharmacists into community palliative care teams. And this is to support medication reviews and patient care in the home setting. We then have Christine Hoffmeyer, who's a former palliative care nurse consultant with 20 years of experience in clinical practice, service development and policy at both national and state levels. Christine is also a care and consumer representative on our National Register of Consumers and Carers at Palliative Care Australia. She is passionate about advocating for person-centred care and ensuring that the voices and experiences of consumers and carers inform our policy and our quality improvements. Please welcome the panel to the stage.
Well, thank you very much, Camilla, and thank you to Palliative Care Australia for the opportunity to join with you. On behalf of Pain Australia, we're just delighted to have this collaboration and we look forward to many more like it. As you can see, we have a fantastic panel convened for our discussion this afternoon. And why Pain Australia chose to become involved with this event is recognising the importance of cross-sector collaboration and recognising that the experience of pain is obviously one of the key issues that are faced by patients as they approach end of life, and particularly during the period of palliative care. It is prevalent, it is an impact that is seen emotionally, psychologically, spiritually, and physically. So it is very much an issue that we need to better understand and understand where there are barriers to enabling the most enabling the most effective responses to that pain, and in a way that prevents people from suffering unnecessarily. So the discussion today is really an opportunity to try and unpack some of those questions. And as you can see, we've got a fantastic panel to help us with that. So I'd like to start by turning to Peter. Peter, your expertise is very much in specialist clinical care and a very long and distinguished career. When you look at managing pain in the palliative care setting, what would you say is the most, how would you characterize the most best practice approach to addressing care in palliative setting?
Yeah, thanks, Simon. The best practice approach, I guess it keeps evolving because the work that we're doing keeps evolving. And if you summarise what Dame Cicely Saunders advocated so many years ago, that total pain concept, the holistic nature of our assessments. But also, I think we need to acknowledge that good pain management is a basic human right to start with. What I've seen over the last 20 odd years is the increasing complexity of the care that's required and the patients that we're looking after. The older group, frailer, coming with many comorbid illnesses. People with cancer are living longer, and they're living longer with potentially complications of treatment, painful feet and hands from side effects of their treatment, which we need to deal with. So the really core tenets keep changing all the time, but communication would be the basic thing that we really need, and our clinicians need education for communication as well.
That's great, Peter. Thank you. And perhaps to follow up on that communication point, Felicity, when you're often engaged in providing prescribing services and the support that you wrap around that, how important is that communication task? And are people able to get the information that they need from pharmacists when it comes to care?
The communication component is extremely important. Most of our patients have multiple comorbidities, so they've got a lot more going on than just their terminal illness. And because of that, they also have multiple specialists involved in their care. And so it can actually become quite confusing to them as to what medications they need to be on, when they should be taking them, when they should be taking them. And so the role of the pharmacist, what I see is really coming in and pulling everything together so we can communicate between the prescribers, with the patient, with the families and carers to try and get everybody on the same page and working together to help optimize pain and symptom management for these patients. As the pharmacist, we can look at what we can de-prescribe. Often medications are prescribed along a patient's journey, but at some stage they either have no further benefit or the risk of taking them becomes too high. And as pharmacists, we can help facilitate conversations between the prescribers as well as the patients as to when those medications possibly need to be ceased. We can also hopefully, prevent hospitalisation for the patients that want to stay at home by making sure that they understand what their medications are, providing medication lists that they can use that are friendly to use, to let them know what medications they're on, why they're on them, and also when to take their when needed medications. Often they get confused about when they should be taking them, and what we want to avoid is where they get to a crisis situation where they're at home and they're unsure what to do, even though they might have the medications at home. They just don't know how to use them. So the pharmacist really ties in everything to bring all the prescribers, the patient, family, carer together.
Thanks, Felicity. And I'd like to come back both to you and to Peter to talk a bit more about where you see some barriers around that best practice approach. But before I do that, I want to turn to you, Christine, and because obviously you bring quite a distinctive suite of experience. You've worked as a palliative care nurse, so you have that experience, but you've also had the experience of caring yourself for I think your husband, or
that's right.
Sorry, that's right.
No, it was my sister.
Oh, it's your sister. I beg your pardon. And I'd like to get your take on: did anything change between your experience as a nurse and your experience as a carer for your sister? And what would you characterise as best practice when it comes to pain management?
Yeah, and it's interesting how your lens changes. You draw on your experience as a palliative care nurse, but the lens change when it's somebody that is close to you. And I've looked after a number of family members who have died, but it was my two sisters who basically stick closer to my heart and my head, probably. And the thing was that I guess I knew the issues that arise for people when you're trying to manage medication. So particularly if you're looking at management of pain, was that you had to make sure that you had access to all the pain medication that you needed. You had to know whether the pharmacist actually had that medication in stock. You had to make sure that you had actually enough for any change that could possibly occur, that you actually had all the subscriptions that you needed, that you, the GP, and that often you couldn't access the same GP, knew the situation you were in, so there wasn't going to be any concerns about accessing that medication. And I guess I was constantly reminded of how much I actually knew about doing all of this and being prepared, but the impact of actually making sure it was all happening, it was all come together, particularly if you're looking after somebody actually at home, and you wanted to keep them at home. Because certainly my experience as a palliative care nurse was inadequately controlled pain and limited access to medication was the thing that was going to bring them into hospital. And so we wanted to avoid that to the nth degree, because it was Mary's wish to be at home. And so it was actually, as a carer, organising all of that. And certainly my mind went to lots of other people caring for people at home who didn't have the experience I had, and what it must be like for them when I still at times felt quite helpless and powerless when it came to making sure that I had all the ducks in the row.
Thank you. And Peter, is that experience that Christine's just outlined, is that a common story that you hear from the carers of those who are at end of life?
It is unfortunately common, Simon, because we've faced over the last few years difficulties in supply of medications. We've lost some medications we relied on, principally for providing pain relief. And when we've been having different strengths brought in to the country, 1 week the patients and family can source 1 milligram per mil. The next week it's 5 milligrams per mil, and the confusion and the risk of errors that come with that. I was doing a home visit a while back, and I could see and pharmacists would have a fit if they saw the home environment, but I saw all of this blue syringe, this syringe full of blue liquid beside the bed. Now, we use this drug called clonazepam, and it's blue, so we talk about the blue drops. This was 5 mils of blue drops. Well, what I thought was blue drops, but actually it was a new brand that we were importing into the country. And I was having a fit, because if that was 5 mils of clonazepam that was going down the hatch, I was very worried about drug errors, but they went and got the bottle and assured me it was one of the morphine syrups that we were importing because of the national shortage of drugs. So there's a real risk for error and accidental death with this change from 1 week to the next. Families chasing around for supplies of medication because the local pharmacy doesn't stock it, or they've run out and they're closed off their order for the weekend. So after hours, weekend coverage, we sometimes have to rely on our paramedics to provide medication after hours. Or I've been asked to write a new prescription because I've written one for 5 milligrams per mil, but we can only get 1 milligram per mil. Or the ampule strengths, I can only get certain amounts. So it's leading to a lot of distress and just adding to the distress that families and carers have. And then the risk for error, which then puts the health practitioner at risk, because if there's an inadvertent death, we know where that will land, unfortunately.
And that story, Felicity, that Christine tells around, which pharmacist do you go to try and secure the medication that you need? How are you and how is the profession responding to that? And could you tell us a bit about some of the trial work you're involved in?
Yeah, definitely. So part of what we need to do is make prescribers aware that there is now the core 4 medications that all community pharmacies should be keeping in stock. That includes morphine, it includes the clonazepam drops, also includes hyoscine, and also metoclopramide to cover a lot of the symptoms that patients will experience at the end of life. So we need to make sure that prescribers know that these medications should be readily available, and also how to use them and what symptoms that they're used for. At the moment, I'm part of the Palliative Care National Pilot, which is run through the Pharmaceutical Society of Australia. And one of the big things that we do is we go to the patient's home. We actually have a look at all of the medications they've got. We reconcile the medications. We work out what they're on, what they're taking, what they need to be taking. We go through with each patient and counsel them on what those medications are for, when they should be using them. We provide that medication list for them so they've got that reference to go back to. And a lot of that we actually need to do is also including the carers and the family. So it's not just the patient. And the other big thing in palliative care is formulation change. Often as the patients deteriorate, they may no longer be able to swallow tablets and capsules. So we have to need to look at formulation changes. And often this happens very quickly. Yesterday, they could swallow a tablet. Overnight, they've deteriorated and now they cannot. So we need to look at formulation changes and to make sure that when we have those formulation changes, we can have those medications available and ready to go. So one of the things we also try and do is get prescribers to anticipatory prescribe medications for when this happens so that the medications can be there waiting for when the carers need to swap over the formulations when they need to. And hopefully this prevents then the patient having crisis care where they do have to call an ambulance to get those medications in the middle of the night because there's not the medical services or the pharmacies open at that time of day.
I was going to add to that I think if you're involved in a specialist palliative care service, that happens. It's the people we don't get to see, the people that are not being referred to us that are missing out on that care and are falling between the cracks. And it's how do we get access to all of those people? And that really relies on all of the healthcare professionals referring at an appropriate time or having that palliative sort of approach mindset as part of that best practice. But that's sometimes not the skill set of a colorectal surgeon or the neurosurgeon looking after someone with a glioblastoma. So it's the people we don't see and the people with chronic heart failure or advanced lung disease that we're not getting to look after or see or support.
Yeah. And Christine, that issue of access to the right level of support, whether it's a pharmacist or whether it's a well-informed specialist in another discipline, do you see these problems playing out in your experience, both personally and also professionally?
Yeah, and I guess I was certainly fortunate to have Southern Palliative Care, where Peter comes from, involved in my sister's care. I've lived for a short time in a rural area where there was no GP. There was a nurse practitioner whose hours were reduced. There was a pharmacist. So I have big concerns for how people manage in the rural regions. And the concept of not having access to medication, the stress that it puts on the carer, to think that somebody's going to end up being admitted to hospital, because if it's not around, they're going to end up in hospital. They're going to stay longer in hospital potentially. It's going to take longer to get their pain under control if things go out of balance. And even the concept of seeing a loved one in pain and distress, not being able to adequately manage that, feeling helpless about what you can do next, really can add to prolonged grief. It's those issues that stick in your head. Even for myself, who had everything pretty well organised, there were still points where, despite all of that, long after my sisters died, you questioned what you actually managed and didn't manage, whether you did the right thing or not. But to have that added stress of not being able to access medication and to try and keep track for somebody with that experience of exactly what dosages meant is huge.
It really speaks to the cost of pain in a broader sense, doesn't it? It's not just an economic cost, it's a social cost, an emotional cost, and I guess it's also not just grief, but possibly guilt as well sits inside of that potentially.
Yeah, oh, absolutely. Yeah. I can remember where there certainly wasn't an issue for either of my sisters, but I found out through my sister was always totally conscious of money, and and whether money was going to be enough. And she wasn't a pensioner when she died. She was only 51. I was mortified to find out that she was actually rationing her analgesia. And that didn't happen because there was a shortage. She was rationing it because of the cost. And so then very quickly we resolved that by stepping in. But that still sticks in my head to think that there was a period of time without my knowledge that she was actually doing that. Mm.
So we have seen, of course, on the issue of costs, the federal government's announced its policy and implementing its policy to reduce the co-contribution for PBS medications. So that's quite substantive, from I think over $30 down to about $25, if I'm correct. So that's a really positive reform in terms of that co-contribution cost. But there are still lots of other barriers, aren't there? So I'd like to sort of get a sense, both from you, Peter, but perhaps starting with you, Felicity, where do you see some of the barriers in terms of access to medication and the types of medication that should be available but aren't? Could you give us your perspective on that?
One of the biggest barriers is the shortages. So medications are constantly coming in and out of stock. So we have to be aware of what's available and to be able to alert prescribers as to what they can prescribe. But, well, I mean, one of the biggest things is you know, we've had hydromorphone used to be available in a slow release form, which the patients could take once a day. Now it's only available in immediate release form and only in tablets. The liquids become very hard to get, but it is one of our preferred opioids in patients with renal impairment. And a lot of our patients at the end of life do have renal impairment or liver impairment, and we do need to take that into consideration when we're prescribing medications. And so we've also used to have something called MS Contin granules. So patients that couldn't swallow slow release tablets could still have a liquid version of a slow release pain relief. And without those formulations, if they need to be on those medications, they have to take them regularly throughout the day, every few hours, to control their pain. So we're losing options for slow release, which actually helps patients. If we do have these slow release options, they're not having to take medications as often throughout the day. So that helps with compliance, but it also helps with keeping the blood level of the medication stable within their bloodstream. So they're not having big peaks and troughs, which is where you often get side effects as well. So if we could, I guess, have better access to a wider range of medications for our patients, that would be ideal, rather than we're constantly losing options and not having replacements for them.
And Peter, from a clinician's perspective, what are you hoping to see change here? Because I imagine you're seeing the same impacts that Felicity's just talked about.
The loss of hydromorphone was significant for particularly really complex pain and people with kidney failure. But the other aspects, not every drug that we use is on the pharmaceutical benefit scheme. So we use a lot of midazolam in syringes. I use intranasal midazolam for seizures or for crises as well, and that's not on the pharmaceutical benefit scheme. So that comes at a cost, and if you're on a fixed income, if you're on a pension or self-funded retiree, it can be a considerable cost depending on how much we're needing per 24 hours. Palliative Care Australia have actually suggested that all end-of-life care medications should be made freely available to our patients that are in need at the end of life for that end-of-life care. And the actual total cost is quite small in terms of dollar costs compared to what we are spending on targeted therapy, immunotherapy. That would reduce a huge burden on families. And I think Christine highlighted that the way someone dies leaves a legacy. And if they are rationing medications because they can't afford it, to see a loved one die in distress, restless, agitated because of pain and angst, it leaves a significant legacy, and we will have let that family down. So I'd like to see all end-of-life care medications that we routinely use be made available free of charge for patients that are receiving palliative care.
I think that's a call that many in this room would echo in terms of the importance of this for the dignity of people at the end of life. Are there other practical steps that can be taken in terms of potentially, say, building domestic capability to supply? Because I know one of the issues is that Australia as a market is relatively small compared to other markets. So there are challenges in just securing that import. Are there practical things around domestic capability?
Before I talk about the domestic supply, I think clinicians and pharmacists talking and collaborating and having that working relationship is really important. Letting pharmacists know what's around the corner, because they can get supplies in ahead of time. So that behoves us to have good communication to our pharmacists. From a practical production perspective, Australia actually is one of the world's largest growers of legal opium. Tasmania, it's a major product. We have the product that we are sending offshore and importing back the finished product at great expense. It falls in line with the government's Made in Australia policy that we should look at manufacturing here. We have purpose-built facilities that are needing support to manufacture. There's a factory that's purpose-built in Adelaide for pharmacy production that's struggling and needs support. So why not stimulate the local economy? Why not actually add to our export economy by manufacturing the product in Australia, stimulate the jobs for the community, spending money in the local community, but being able to export it and retain our sovereignty in medication supply? We've got the raw materials. How do we value add to that?
And Felicity, I saw you wanting to jump in there. Was there something you wanted to share around your perspective on what you need access to from a pharmacist perspective?
I wholeheartedly agree. It'd be great to see manufacturing in Australia. I guess it is just we need to resolve these shortages that are continually happening. And if we don't do that, we're constantly looking for other options, and our options are getting narrower. So, we need to find other ways to make this work, and potentially manufacturing in Australia could be a great way for us to ensure that we have that supply.
And Christine, how about from your perspective, what would you like to see change in terms of the medication availability?
Well, I was certainly fortunate enough when my sisters were, I suppose, where there wasn't any issues with access to medication. And to think of the stress upon the carer when they weren't able to access it, or they had to completely understand how the dosages might change because the actual strengths of the morphine is different, would be significant. And I guess the access to the medication for people in the rural and remote areas, if it's bad enough for us here in the city, what's it like for people in the rural remote regions who actually don't have as much access necessarily to the specialist palliative care services, or even to a regular GP or the nursing services? That is a significant impact upon them.
Well, I think you can see we've heard some really great perspectives this afternoon when it comes to managing pain at end of life. And while so much good work is done at a clinical level, through carers, through pharmacists and a whole range of other disciplines, we still see far too many people not able to access the care, particularly the coordinated care that they need, but equally access to pain medication that can substantially improve people's quality of life is still a really troubling story. And I guess what I take away from this discussion is we shouldn't be in this situation where people at end of life are having to navigate the complexity of access to what is fundamentally, as you say, Peter, something that should be freely available and without an economic or financial burden. So I hope that's given everyone some food for thought, and please join me in thanking Peter, Felicity and Christine for their contributions today.
Thank you to the panel. And something we prepared earlier, in fact, a year ago, was an 11-point plan, which we have 6 other health peaks signed up to. And I think Peter is going to come back to the stage and speak briefly about our 11-point plan, because that critical pain shortage that we are, medication shortage that we are experiencing in Australia requires action from our politicians and from our industries. So Peter, can I welcome you back to the stage to talk about that briefly?
Thank you, Camilla. We've heard about the shortage of essential medicines in Australia, and it is having a devastating impact on patients and carers, especially those nearing the end of their life. The medicines, as I've talked about, are often not freely available at their local pharmacy, especially after hours, and this necessitates a search around the community for palliative medicines, particularly pain relief medication. Our clinicians and our pharmacists are caught in repeated cycles of adjusting treatment plans, rewriting prescriptions, and depending what's available this week or the week coming. The risk of medication errors from the different formulations and the confusion that carers face only compounds their distress and frustration. The 11-point plan to resolve shortages of palliative medicines was led by Palliative Care Australia and 6 other core peaks. And they were Pain Australia, the Palliative Care Nurses Association, the Australian and New Zealand Palliative Medicine Association, the Pharmaceutical Society of Australia, Advanced Pharmacy Australia, and Ageing Australia. And it outlines the necessary steps to resolve the medicine shortage. And I'll just highlight 3 of them. And I've already touched on one. Making medicines free for people at the end of life would have a significant positive impact on that family, not just economic, but holistically, their mental health, their well-being. Creating a national stockpile of critical medicines when there is a risk to supply, and mandating that it's 12 months supply, not a few months supply. And I've touched on this. The 11-point plan aligns with Made in Australia. Developing the sovereign medicine manufacturing capacity would stimulate the economy and provide export opportunities and safeguard our communities. The complete 11-point plan is available on the Palliative Care Australia website, and I urge you all to explore the 11 points and consider how you may help to resolve the palliative medicines shortage in Australia and ensure that care is available to all Australians, regardless of where they live, in the city, metropolitan, peri-urban, rural and remote communities. They deserve the same equal access to care. So thank you very much.
Thanks again to our panel, and particularly to Pharmaceutical Society of Australia for sponsoring today's event. So today's discussion marks another significant step forward. Pain at the end of life should never be inevitable. Through collaboration, innovation and compassion, we can ensure every Australian receives the care they deserve in the final days. So let's all continue working together to ensure that no Australian suffers needlessly. Thank you for coming today, and I hope you'll take the time to catch up with each other before you leave today. Thank you.